Yes, so my name, you already have seen me probably in the other room. I have a lot of Waldenstrom patients in my own practice as well as in the clinical studies. And in my ongoing study in Germany, we have 240 patients with Waldenstrom. That's quite a lot. That is German population. And I have some experience with that disease. So you may ask questions, and we will go through the prepared questions which are on the screen, which comes from your side. They have been collected. So feel free to ask any question in between. I would like to start. Regarding patient side effects with bendamustine, does the literature summary below give a fair picture? Most people will not experience all of the side effects listed. That's a complex situation. Not all people will experience all side effects. So the sentence is true. Most people will not have all the side effects, but probably most people have at least one. So you have to say at least the treatment with bendamustine and all other chemotherapy in most circumstances is making 1 or 2 or 3 side effects. That cannot be avoided. Some patients really go through the treatment, but this is probably very small probability. Side effects are often predictable in terms of their onset, duration, and severity. Yes, however, not for 100% sure that you can predict it. Sometimes you are surprised that the patient gets a very rare side effect, which was not the experience with the other 100 patients, and sometimes the very predicted side effects are not happening to the one patient. So you never know really, and that is what we learned from our studies, that we have some statistical expectation. If side effects appear, they are almost reversible and will go away after therapy is completed. Also, that is not 100% true. Sometimes you have a little damage of any tissue, like maybe the blood count is a little bit lower after the treatment, and this stays for a long time. But in general, yes, the side effects go away and stay away when the treatment is completed. That is in general the situation. Common side effects are low blood counts, that's true. It's not true that you see an increase in bilirubin levels. No, that does not happen. Of course, as a doctor, you never may say that does not happen. In 1 out of 100 it happens, but bilirubin elevation is not a common side effect of bendamustine. Less common is infusion reaction, like chills, fever, itching, rash, mouth sores, fever, nausea, vomiting, fatigue, diarrhea. Also, that is not quite true with bendamustine. Infusion reaction with bendamustine are very, very infrequent. It is more to do with rituximab, not with bendamustine. Bendamustine, of course, can make some long-term reaction, like some skin irritation, as I told in my presentation. That can happen, but you won't experience it in the chair when you get the infusion. That usually goes without any complication. Mouth sores, very rare. Fever, very rare. Nausea happens in 30% of the patient, and it's a delayed nausea. It's not a nausea while you're sitting in the chair and get the treatment, but after 1 day at home, you're starting to feel a little bit sickness. And this holds on for 3-4 days. So on Monday you start the treatment, on Tuesday you get the second treatment with the bendamustine, and then when you come home, yes, you feel some kind of sickness, and this lasts for 1 week. That can happen in 30% of the cases. We have good effective treatment against it, but certainly not always it can be avoided with a medication. Fatigue is also side effect of bendamustine, again in 30% of the patients. Some patients really feel tired, the week after the bendamustine administration. They tell me they don't go to work, they are tired, they don't have any motivation to read the newspaper, they are really tired. But after 1 week it goes away, and usually the patient is back to his strength or even better. That happens in 30% of the cases, and it cannot be predicted. It happens or it does not happen. So if you would think about it, nausea a little bit, not very severe, some fatigue, you would say, okay, if that is all, it's easy. I think about much more severe side effects. And indeed, fatigue and nausea is the most what the patient are feeling after bendamustine treated. As it stands here, diarrhea is not a common side effect of bendamustine. It can happen, but usually because of the medication bendamustine alone, it does not appear.
How can you best prepare before you have treatment? Prepare your body.
How can you best prepare before you get the treatment was the question. You get some pre-medication by the doctor, which you usually, at least in Germany, makes you a little bit tired because you get some anti-allergic medication. Beyond that, I would say I have no idea how yourself can prepare for the treatment. Usually you go to the treatment, you get it, and no other chance than to wait if you experience the side effects or not.
I guess I'm thinking things like diet, exercise, those sorts of things.
No, diet will not help you at all. Exercise will not help you to tolerate the treatment. However, exercise is very good for your general health, and if you're in a good general health, you can tolerate the treatment better. Any comment from you?
No, I think the main thing is if you can make sure you keep a well-balanced diet and healthy, then you're putting yourself in the best stead to be able to tolerate the treatment. I think psychological preparation is a big thing as well, and a lot of people have anxiety before they start the treatment. Once they start, they realise actually it's not as bad as what I thought. And usually I find that before the first day, people are really nervous, and once they're sitting in the chair or there is just the infusion, they actually, oh, it's not as bad as I thought. Certainly, we've got excellent psychologists here, and I'm sure most hospitals do. And sometimes it's worthwhile thinking about asking for a referral before you start, and that can be good because not everyone feels comfortable, burdening in some ways their family, talking about their problems, and certainly the doctors as well. And so it's nice to have someone who's completely removed who you can open up to and have a good chat.
Just wondering if you have some time, I wanted to understand more the distinction between WD and the other indolent lymphomas.
More or less, the WM, you mean Waldenstrom disease, and the other indolent?
Yes, yeah.
Waldenstrom disease is from the biology very similar to other indolent disease, but it's totally different from its specific disease characteristics. It's expressing this one protein which is called IgM, immunoglobulin M. This is done by one cell group, and it's being produced and produced and produced, and there's no stopping signal. So the cells are producing nonsense, and that is a problem with Waldenstrom disease. Because of that rising protein, the hemoglobin, the red blood cells, go down and you feel weak. So both is not good. IgM is rising, a protein, too much, not good for your health, and the blood cells, the red blood cells, hemoglobin go down and you feel exhausted and tired. And that is different from the other low-grade lymphoma. But the dynamic evolvement of the disease is similar. It's a slow-growing disease. It's not acute, like you have a problem today. It's slowly coming, and it's slowly going when you get treatment.
And does it respond as well to similar treatments as the others?
Yes. So the response rate in my study was very comparable to the other disease entities. And the response duration, which is a long-term good effect of treatment, also is very comparable to what you see in the other indolent lymphomas. I have one curve with a long-term outcome of all these different diseases, and they are all the same, overlapping curves. I go to second question. What are possible serious complications of bendamustine therapy? Do I agree that a rare but serious complication of bendamustine therapy is tumor lysis syndrome, and a large number of cancer cells are rapidly killed by the therapy? The release of the cells into bloodstream can lead to kidney failure. I do not agree. That does not happen with bendamustine. So, wrong information, whoever found this. That happens in different kind of lymphoma, for example, Burkitt lymphoma or any aggressive type of lymphoma. Bendamustine is not known to induce tumor lysis syndrome and that kind of complication. As again, one should never say no, it does not happen, but in general, 99% it's not possible with bendamustine. Number 3, are there long-term consequences of using bendamustine? How much is known of the long-term safety profile of bendamustine? Because bendamustine is an alkylating agent, it is likely to be potentially harmful to stem cells. Somebody is really an expert who writes that question.
Just go to our blog.
Okay. So any chemotherapy, any treatment may have long-term consequences. The most feared long-term consequence is that this damage is so toxic to your body that you may have a second cancer after 10 years. Or after 5 years, getting a second kind of malignant disease. Because, as you may anticipate, chemotherapy by itself is a toxic agent. It should be toxic against the disease. However, also it is toxic against the healthy system in the body. So it can make a damage that your body can produce or can let the situation happen, a second malignant disease. That is well known, that is true with every kind of chemotherapy, and it's very hard to say if that's a high risk or a low risk and to give a special precise estimation. We have looked for it and we found 23 patients within 5 years after the treatment out of 260, so that is approximately 8% having a second type of cancer after the treatment. We don't know how many percent of the patient would have that kind of treatment, cancer, if they would have not had bendamustine. So many of the second cancer are prostate cancer in a 75-year-old man. That happens in the normal population also. Of course, there are some colorectal cancer, some lung cancers, so you never know. Would that have happened also when I would have not had Waldenstrom disease and would have not bendamustine? But at that moment, we at least discuss the potential association to the treatment. So that is the most serious long-term consequences, that you have an increased risk of a second malignant tumor after a while.
Do you see many skin cancers? Is that one? Do you include those in the 8%? Or?
Yes, of course, the basal cell carcinoma, the white skin cancer, yes, we see them. However, to be honest, I don't have any idea how often that does happen in the otherwise healthy population who has the same age. I don't see these patients because a healthy patient is not coming to me. So I don't know if that happens more or not.
Because, you know, in Australia, obviously, we have big problems with skin cancer, and that's certainly one of the things that we see here is that skin cancers potentially are more common after chemotherapy. And so we always advise, you know, skin checks in our patients who have finished chemotherapy.
The other...
Professor Rummel, one of the patients who's had bendamustine a couple of years ago, the session mentioned that they'd had amyloidosis. He's not here to ask the question specifically. Is that reasonably common, or...?
Amyloidosis?
It's the one that stops the production of the red blood cells, isn't it?
Amyloidosis is a growing of a protein in the tissue, and it makes tissue damaging. And this is a very rare complication by the disease itself. Probably it has nothing to do with the treatment of bendamustine. The other question was the choice of bendamustine can be potentially harmful to stem cells. Very complicated question, because the stem cells are needed when you want to make a stem cell transplantation. That is a very, very infrequent and rare treatment option for patients with Waldenstrom disease. So usually that question probably does not play a relevant role. In particular, when you are older than 60, 65, that kind of aggressive treatment with stem cell transplantation will not be discussed for your disease. But that question from the scientific aspect is very interesting, because that really the doctors want to know if stem cells are damaged or not. What is stem cell? Stem cell is a cell of origin in your bone marrow which is producing all the next blood cells. So if you damage with the chemotherapy the stem cells, the mother cell of all other cells, that could be a relevant problem for your future. And for that moment when you want to do a stem cell transplantation with your own stem cells. Very complicated issue, and the answer is bendamustine can be potentially harmful to stem cells, but in average you can make that treatment procedure in the future even when you have had bendamustine as a prior treatment. So in Germany, in these very rare circumstances that you want to collect your own stem cells for that aggressive treatment procedure, in 90% of the cases it is successful. So that is the answer to that question, and it's a very complicated answer.
Yep.
I'm just really interested in the fact that in Germany you have a very strong practice of WM clients, patients. I'm keen to hear what your key learnings are from that practice. What are the things, having dealt with so many patients with WM, what do you extract from that? What are some of the insights that you've gained from that?
So what is the question? What is my...
The question is, given the strong practices you have with a particular type of patient, a WM patient, what are your key learnings from having all those patients? What,
Key learning of having such a wide group of patients: be very defensive with treatment strategy. Make it conservative. That is my key lesson, what I have learned. So not make a big and fast jump into something, but really be slowly acting, slowly thinking, and making a very mature decision. So usually when it comes to treatment, you make this decision within many months. Yes, you don't have to make it tomorrow, but you suddenly start to think, oh, now it looks like maybe the disease becomes a little bit more speedy and faster, maybe not. And so, that is my key learning. Second key learning, you cannot get the disease away from your body with that kind of treatment. So you have to respect the integrity of the body, and you have not to overstress the treatment. So better don't do the maximum, but do 4 or 5 cycles with a rather moderate treatment, and to do not exhaust your capacity. That is my key lesson.
And do you have a sense as to why you say that? why would you say that? Is it something that you know of? Is it because it's indolent and so slow growing that you might as well take your time about it? Or
So why am I saying that? That is, as you want to say, not written in any journal, what I'm saying.
Yeah.
You asked me for my personal experience,
That's fine.
and that's it. This is gut feeling and doctor's experience, and the very good question is, how would I treat my relatives? That is what I want to say. I mean, how can you say that is your experience? You do it for 10, 15, 20 years. You learned some situation which were not good, which were excellent, and so you make your feeling.
May I comment on that?
Yes,
I think sometimes that the watch and wait approach means that patients may have a lesser quality of life than more intentional treatment that allows for a better quality of life sooner and for longer.
that is probably one individual experience, but it's not the vast majority. When I see my patients and they have an IgM of 4,000 milligram per deciliter and a hemoglobin of 11 gram per deciliter, and I ask them how they are feeling, and they say, I'm still playing in my tennis club every weekend. I say, fine, it's good. We see you again in 3 months. And he will go out of the office and he feels happy because he saw my reaction, and I'm very firm in my saying, okay, come back in 3 months. I don't think that patient has a low quality of life. If you make a lot of concern as a doctor, IgM 4000, I have to think about, you suddenly start to feel less good. Yes? So I don't want to say that it's correct what you're saying in general. That clearly is in some individual patients that they don't like the watch and wait and they don't feel a good quality of life. But the vast majority of patients enjoy it.
Professor Rummel, could I just ask, back referring to your lecture earlier, when you were talking about the comparison between VR and chopper, you were mentioning the toxicity of adriamycin. Can I ask, like adriamycin, is there a lifetime cumulative dose concern that you would have with re-administering bendamustine subsequently, if you had a very good response with it?
Yes, that comes to the question if you can repeat treatment with bendamustine. The answer is absolutely yes. Doxorubicin cannot be repeated ultimately because you have a limited cumulative toxic dose. Bendamustine can be given. How long you are tolerating it. The only limiting toxicity is the blood cells and the cytopenias which arise from the hematotoxicity. If you get bendamustine rituximab in the year 2000, probably you can get it in the year 2005, probably again you can get it in 2010, and probably in 2015. You just must not exhaust the bone marrow, which has to generate always new blood cells. With doxorubicin, this would not be possible. But with cyclophosphamide, it is possible. More questions from your side? I continue with question 4. Are you a member of the Consensus International Workshop Panel for Waldenstrom patients? And will you please speculate on the treatment recommendation in 2016? Yes, but this is not a very tough question. I can speculate that in 2016 it is the same as in 2015. So time needs much longer before you can make a real treatment change. And probably that comes back to the question of the new compounds. For example, ibrutinib, probably later on there is some question, and we need to wait long time before we can put it into the algorithm. So I would speculate in 2016. First speculation, there will not be another recommendation Second, because there's not so much change. It will be done probably every 2, 3 or 4 years, even only then when something is really very new and makes a change in the treatment strategy. Bendamustine was added as a new treatment option based on the results of my study. Bendamustine was observed to be superior in the 5th year, but further follow-up studies are needed. And that is all true. Bendamustine was added, and that took also some time. The study was done in 2003, but only in 2013 the bendamustine was added. And that is mainly to do something that the bendamustine is not available in all countries of the world 3 years ago. It is an old drug, 50 years old, but it just comes to the different countries of the world. And the reason for that is also interesting to let you understand. The drug is 50 years old. Therefore, there is no patent and protection for the data on that drug. The patent only is for a new development and lasts maybe 10 years. And because there is no patent, probably many companies couldn't make the bendamustine, and because many companies could make it, there is no big company who is interested in supporting the development of that drug worldwide. Probably that is the reason why it took so long that it goes to all the countries in the world. If there would be a really huge pharmaceutical company behind it, like Roche, Novartis, Bristol Myers Squibb, it would have gone much, much faster through the world. That is probably the explanation. And mature studies, including bendamustine, provide durable responses. Yes, and further follow-up studies are needed. As I showed you in that one curve, we have observation until 10 years. We will again report in 5 years from now, in 4 years from now, another update. If I personally, I'm still in a healthy condition, I will have another look for the data. The interesting thing is that we did this study. I told you in the one slide, it's an investigator-initiated trial, so the study was initiated by myself, by a doctor. And therefore I have the chance to continue to ask if the patient is still alive, if he needed a second-line treatment, if he has any serious long-term consequences, and so on. If it would have been a pharmaceutical-driven study, the study closed it at a special time point, and after that nobody asks again for long-term data. That is the difference between these two kind of studies. And because I'm a doctor, I may ask my German doctor colleagues, what is with your patient? And he gives me the answer. There's no data restriction for that.
5 more minutes, please.
Yeah, I was going to ask if there are any burning questions.
Yeah, thanks. Just wondering what your view is on, I think it's called plasmapheresis.
Plasmapheresis is a very old treatment. It was used 50 years ago. It just filters out of the blood the protein. It does not treat the disease. It just takes away the protein. It's an excellent treatment with a long logistic way. It needs a lot of preparation, complicated thing, because you need access to the bloodstream and you need to filter out the protein from the blood. I know by chance some patients doing it now for 20 years, continuously. Every 6 weeks going to this department, going to the machine, both arms, blood goes out, blood goes in, and the protein is filtered. One cannot recommend it as a standard procedure, but it is effective treatment, in particular when one patient is newly diagnosed and is threatened by an extremely high protein. Then you need to take it out of the blood immediately, and that only can be done with plasmapheresis.
Is there a downside to it? Is there a downside to it? Are there any side effects of having plasmapheresis?
No.
monitoring when you're using bendamustine?
Residual disease monitoring bendamustine. So it's a complicated thing, residual disease. In every disease it's different. In Waldenstrom it's rather simple because...
I just wanted to ask a specific question about, that's the title, but the specific question I want to ask is about the serum marrow discordance and the issue about then if you're monitoring in the serum, then and you've got a discordant currents going on in the marrow, so that you maybe have dramatic reduction in the marrow and nothing in the serum.
Yes.
What's the answer and how do you go about it? Is it widespread?
So personally I only look for the blood and the serum paraprotein. I don't make a bone marrow puncture, and the serum discordance gives me a good insight into the disease. As minimal residual disease, the immune fixation of the monoclonal paraprotein can be used, and in most circumstances, and unfortunately, it is still present. It does not go away. That is a sad information about this whole treatment, and all other treatments are not able to eradicate the disease to 100%. And the discordance is that you mean the IgG is low and the IgM is high.
No, the discordance I'm talking about is when you start bendamustine, and actually it works in the marrow, so you get a dramatic reduction in the marrow infiltration. But in the serum where you're monitoring it, it may say you might get a 90% reduction in the marrow, but if it's in the serum it only is 25%, you think, oh, it's not working. But in fact, it's a discordant.
That's not a surprise because the protein has a long half-life. So the protein which is produced is swimming in your blood for weeks until it gets cleared. That is the problem with it. So again, be patient and slowly wait, and the IgM still goes down even if you have stopped the treatment. My patients sometimes have 1 year after end of treatment even a lower IgM than after the end of treatment.
So you don't call the therapy is not working?
No, no.
Because you're monitoring in the blood is the issue I'm asking about. Is it a widespread phenomenon you've seen with the use?
Yes.
In Germany? Yeah.
Any other questions?
The next one.
Just what is the half-life?
Number 9, is that what you're saying?
Reuse of bendamustine, yes, can be used again if it's not too fast about after the previous bendamustine. That's a question. So after 1 year bendamustine and you need a second line treatment, I would not use bendamustine. First, it's too early, and then the toxicity of bendamustine is accumulating. Second, it does not make sense to retreat with bendamustine if the treatment duration is so short. When the response is only lasting 1 year, that does mean the treatment was not good. Therefore, I would make a change of the treatment plan. But after 3 years, when you need a second line treatment, you could easily make another treatment with bendamustine, and if it's 5 years away, nobody has any risk for doing that.
Did you have a question?
I gather that your treatment was based on bendamustine rituximab combination. What would be your comments in regards to a person that has a severe allergy to rituximab and was contraindicated to use that? Can it be used alone?
So bendamustine rituximab probably is better than bendamustine alone, probably. There's no direct comparison for that. And if somebody cannot tolerate rituximab, you can treat him with bendamustine alone. Of course that is possible. And probably the effect's also good, but maybe not as good as if you have had 2 drugs like rituximab. There are some new agents like ofatumumab, which is different. Sometimes I try to give the patient the other one. Sometimes it works, sometimes not.
It's not available in Australia. Not approved.
Yep.
Do we know the half-life of the IgM paraprotein?
Yes, one knows. I don't know it exactly. I'm not a biochemist, but you can look into the textbook. But it's certainly above 6 weeks or so.
It's generally, we know the effects. It could be problems with bendamustine in terms of extra other cancers and that. What about any work done on cognitive?
Cognitive?
You know, the deterioration of the brain with these chemicals. Is there any work that's been done on that?
No, I have not heard about that. Occasionally, some patients tell me after the treatment that they are not 100% back as their cognitive capacity. They tell me. However, with my experience, many cancer patients tell me something like this with different kinds of treatment. So I would say it's not a specific thing of bendamustine, but it's a specific thing of anti-cancer treatment, that some patients suffer from not fully reconstitution of their capacity in thinking, concentrating.
Thank you.
Thank you very much.